Welcome everyone. Welcome to our monthly seminar from the Cancer Cachexia Society. We are very happy to have you here. Thank you for joining. Welcome everyone. We are really happy to have this monthly seminar in June with Dr. Dan Runco. So I'll just wait a few seconds to have everyone entering the room. And so I think now we can start. So thanks again for joining us. Welcome to everyone to this June seminar. So it's a monthly seminar from the Cancer Cachexia Society that is coordinated by the Educational Committee. I'm co-chair of this committee. So my name is Laure Bindels. I'm an associate professor at the Université Catholique de Louvain in Belgium. And it's really a pleasure to chair this session together with Professor Fabrizio Pin. Today I have a few announcements for you that I would like to share a few updates about the society. So the first one is about our Cancer Cachexia conference that will take place in September in Torino. For those of you who are familiar with the society, you know that we organize a conference every 2 years about our topic, so the Cancer Cachexia. And so this year it's in Torino. The poster presentation deadline is in 2 days, so you still have time to submit your poster. And we are very much looking forward to all the science that has already been submitted and that will be submitted. We have also organized this year a scientific image contest. You have all the information on our website. It's a very simple application. You go with a nice picture that you took of your research and a small legend, and we organize a sponsorship or a contest where we can advertise your research. So deadline is the same in 2 days. So we are really looking forward to your picture. For some of you, you may already know, we have a Cancer Cachexia Society account on Blue Sky. Anisha Dasgupta have put together a startup package, so please feel free to join. We'll put the link in the chat, and we love to have the conversation and continue the conversation online with you. And then finally, we have a job board session that's organized on our website. So basically, any members of the society that have a position that is open can reach out to us to the email of the society, and we can post the position there. And so it's really a great place to advertise any open position you have. So we'll put the link in the chat as well. Our next seminar, so today's seminar is with Dr. Daniel Runco that I will introduce in a bit. I would like to also introduce our next seminar. So it will be in September, on September 10, as usual, 12 p.m. EDT or 6 p.m. CEST. And we will have our 8th trainees talk. So we have selected 3 early career researchers that will be presenting their research. It's Mr. Jonas Sorensen, Mrs. Amanda Piveta-Schnepper, and Mr. Gabriel Guarnaccia. We will be talking about their PhD research. So as usual, everybody is welcome, member and non-member of the society. But you need to register for the webinar. So you can find the link for registration on our website, and you can also find the link on our social network where we share this. And also, if you are a member, you get all the email from the society, and so it's very easy to register. So we are really looking forward to see you there. So in September, we have another day that we would like for you to mark on your calendar, and I will leave the floor to Dr. Brittany Kantz about that. Dr. Brittany Kantz is from Ohio State University.
Thank you. So I just want to remind everyone, if you haven't heard about it yet, the first ever Cancer Cachexia Awareness Day will be this September 26th. It's a Friday. It's during the conference. Shortly, probably in the next month or so, you will be given updates on what we're planning to do. In the meantime, we're working to make it official to have a resolution. And this will be through the United States, but hopefully we can make it spread far and wide. And we just want to give thank you to everyone who has supported it thus far and everyone who has helped get this going. So I just want to remind everyone, Friday, September 26th, and it will be every 3rd Friday of the year following after. The last Friday of September following after. So thank you.
Thank you very much, Brittany and Dr. Kantz, for putting everything together. So don't forget to put it on the calendar and stay tuned for more ads. And so without any further delay, I would like now to introduce Dr. Daniel Runco. So thank you very much, Dan, for joining us for this webinar. So Daniel Runco is a pediatric neuro-oncologist and cancer cachexia researcher at Seattle Children's Hospital and University of Washington School of Medicine. He received his bachelor degree at Creighton University and then did med school at Loyola University in Chicago. And then Dr. Runco completed his pediatric residency at Indiana University School of Medicine, Riley Hospital for Children, and then he also served there as chief resident. After that, he completed a fellowship in pediatric hematology and oncology at Children's Healthcare of Atlanta Aflac Center and Blood Disorders Center. And in the same time, he received a Master of Science in Clinical Research from Emory University. So Runco research has focused on nutrition, supportive care in children that are undergoing cancer treatment with the hope of identifying mediator of cancer-related cachexia and then bring novel therapeutic to children affected with cachexia. I think it's a really under-discussed topic, cancer cachexia in children. Dan, thank you very much for joining. We are really looking forward to your talk. Thank you very much.
Thank you, and thank you for having me. Let me get my slides here. And so hopefully I've shared properly and you can see the slides.
Yes.
Oh, great. Yeah, thank you so much for that kind introduction. And I too feel like this is a really understudied and really important area that we are hopefully generating some more interest and scientific rigor in focusing on, because what I'm going to talk about today is renewed opportunities to identify and treat childhood cancer cachexia. As mentioned, I'm at the University of Washington School of Medicine and Seattle Children's Research Institute. And this is a really interesting area for me, particularly because of the clinical implications. You can see I'll talk through this discussion about how it affects the day-to-day lives of children affected by cancer and their families, but also some really unique research, basic science and clinical research challenges that we face in talking about children specifically. So I do have a couple disclosures. I have done consulting for Pfizer with regards to pediatric cancer cachexia, and also day one, which is not relevant to this presentation. At Seattle Children's, we include a slide like this at the beginning of any talk that we give, basically recognizing that there are traditional unceded lands of many communities that existed across the Pacific Northwest portion of the United States. And our institution thinks it's really important to honor and have gratitude for the land, the peoples, and the tribes that have been here past and present, and not to take place of having authentic relationship with these communities, but just a way to honor and respect the people and the land itself. So during this hopefully 45 minutes with plenty of time left for conversation and questions afterwards, the objectives today are to review some of the importance of nutrition and treatment of childhood cancer. We're going to describe some of the unique challenges specifically with regards to pediatric cancer cachexia research, and specifically how that compares to adults. We're going to talk about the potential role of GDF15. It's a particular area of interest of mine for research, and how that might be a mediator of that cancer cachexia. And then we're going to wrap up the talk focusing on opportunities for pediatric-specific cancer cachexia study, and some of the things that actually the society is working on right now to emphasize the importance and the uniqueness of childhood cancer cachexia. So first, we're going to talk about the importance of nutrition in children undergoing cancer treatment. I don't often have to emphasize the importance of nutrition to the Cancer Cachexia Society, but oftentimes when I speak about this to other oncologists, there's some baseline information and background that's really important. And when we used to think about kind of the old paradigm of how we treated cancer, we had a child that was diagnosed with cancer, you cure the cancer, and you worry about everything else later. You know, it was kind of you can't worry about the long-term side effects if you don't cure the child's underlying disease. And luckily, in the area of pediatric oncology, we've gotten much better about curing childhood cancer. So of all children diagnosed with cancer, the overall survival rate is about 70 to 80%. And so we recognize the importance of everything, the morbidity in addition to the mortality that comes along with childhood cancer treatment. But really, over the last couple decades, there's been a new paradigm shift in treating pediatric cancer. And what we realize is there's a lot of different kind of non-organic things that actually go into our ability to cure cancer and our ability to deliver optimal therapy on time and minimize the side effects. So along the top, you see things like financial stability, infection, quality of life, and emotional well-being. All those things are crucial in a family being able to show up to clinic, be able to receive care, and be able to for that child to be able to tolerate the oftentimes highly intense therapy that they receive. And along the bottom, three areas that are particular interest to me: health literacy, nutrition, and physical activity. And we know that those are crucial in making sure that we keep the therapy that is prescribed on time and optimally dosed so that we are maximizing the therapeutic effect and minimizing any long-term toxicity. But more to the point is malnutrition impacts outcomes in childhood cancer and childhood diseases in general. Malnutrition increases morbidity. So children that experience malnutrition during cancer therapy have higher rates of bacteremia and febrile neutropenia. Those kids who experience malnutrition have decreased school performance and increased problems with cognition. And experiencing malnutrition earlier in life actually leads to more severe and potentially irreversible consequences. The direct impact on overall survival still remains a little bit under debate just because of the inability to kind of draw those direct lines. But as I'm going to talk through this presentation, there's a lot of things about malnutrition and ultimately cachexia that affect our ability to prescribe full dose chemotherapy, keep it on schedule, and have patients able to tolerate it. But more importantly, malnutrition is complicated, and it's complicated in adults, but I would argue that it's actually even more complicated in children. On the left side, you see anthropometry, so different ways that we can measure body mass, body composition, weight, height or length, skin fold thickness, mid-upper arm circumference. And in kids, because kids are expected to grow, we use z-scores, kind of normalized measures to say, how big is a child supposed to be compared to how big are they? We have reference charts, at least in the US. Well, the first you'll see there is the World Health Organization for kids 0 to 2, and then the Centers for Disease Control between 2 and 20. And then when we think about the etiology and the chronicity of malnutrition, that can be non-illness related, so behavioral, socioeconomical, or environmental, or it can be related to illness. So you can have acute, as the paper in 2017 pointed out, acute problems like infection, trauma, or burns, or chronic, things that last longer than 3 months, like cystic fibrosis, chronic lung disease, or cancer, all things that affect the body's utilization of nutrients and the ability to kind of absorb those nutrients. And then finally, you see that with some of these chronic conditions and some of these acute conditions, they come along with or without inflammation. And those things all really affect the mechanism of malnutrition. So at the top, you see starvation related to anorexia, socioeconomic or iatrogenic feeding problems. And that really results in kind of a decrease in intake. On the converse side, those illness-related acute and chronic features here can affect malabsorption, increase nutrient loss, and result in a state of hypermetabolism, which increases energy expenditure. And then, of course, we all know that inflammation can alter the way that nutrients are utilized in the body. And kind of to the right, you see increasing that nutrient requirement. Ultimately, malnutrition results in an imbalance of intake related to requirement. That can be related to energy itself, calories, or protein, and then can result in several micronutrient deficiencies, which themselves have impact complications of cancer-related therapy. And then finally, a lot of complicated outcomes that can be measured: loss of lean body mass, muscle weakness, developmental or intellectual delays, infection and immune dysregulation, which is particularly important in our immunocompromised patients, and then delayed wound healing and prolonged hospital stay. So I'm going to talk a little bit later about how these specific outcomes pose unique challenges for children going through cancer treatment and our opportunities for cachexia research. So as I mentioned, children are supposed to grow, and it should go without saying, but creates a novel challenge with regards to how we assess nutritional status in adults. Weight and height are supposed to be more static. And I don't want to get into the, when we get to aging or some of the postmenopausal changes in body composition. But overall, over the course of adulthood, weight and height are ideally more static. Children are supposed to gain weight and they're supposed to gain height. So failure to grow is actually abnormal. And rates of growth change during infancy, childhood, and puberty. So not only do rates of linear growth change, rates of weight gain change, but body composition changes, particularly pre and post puberty, with how muscle, fat, and water are distributed in the body. To emphasize this point, I've put up here a growth chart from the CDC. And along the top, you see these length measurements. And along the bottom, you see weight measurements. We use this to kind of, as I mentioned, provide a normalized measure of how kids are supposed to be. So hopefully you can see my cursor here. But on this side, we have birth. And all the way to the right side, we see 36 months. So this is the first 3 years of life. And kids are plotted along that graph. You see early on in infancy, the rate or the slope of gain is actually higher. And as you get older, that slope levels out a bit. And so that provides a unique opportunity, a unique challenge to basically defining what cachexia looks like, because the body composition of these children is naturally changing. That muscle mass and fat mass changes with age, as I pointed out. And to highlight this point, I've put these dots here along the growth curve. Let's say we diagnose a patient with cancer at the age of 2, and they're right above the 50th percentile. If they maintain exactly that same weight through 12 months of therapy, at the end, when they're 3 years old, they're going to be below the 25th percentile. And that's a really big, significant change that has long-term clinical implications. So as I mentioned, percentiles are one way, but there are multiple ways to diagnose malnutrition in children. And I should say, a lot of times at the beginning of these conversations, we use the term malnutrition or undernutrition because that's what we're left with. I'm going to talk with some of the challenges around defining childhood cancer cachexia, but I'm intentionally using the term malnutrition and in some instances undernutrition to focus on this point. When you have a single time point measurement, what you see here is these are primary indicators of how we would define malnutrition in kids. That was published back in 2015, so getting 10 years old at this point. The first, on the left-hand column, you see weight for height z-scores, BMI, length for height, and mid-upper arm circumference, and z-scores, which are normalized measures to say, what do we expect a child to have at that point? Mild malnutrition generally falls into any of these measurements that would be between -1 and -1.9. You can see that moderate malnutrition is there in the middle at -2 to 2.9, and more severe malnutrition is -3. So a significant drop in a negative z-score is diagnostic for malnutrition in children. And when you have multiple time points, you can actually use, again, these indicators along the left-hand side. Weight gain velocity, so how much weight is a child supposed to be gaining and how much are they actually gaining. Weight loss, which is really only applicable between 2 and 20 years of age. Deceleration in that weight for length or weight for height z-score, and inadequate nutrient intake. So similarly, if you follow along across the table, mild malnutrition is less than 75% of their expected growth velocity, or a decrease in 5% from usual body weight, or that decline in weight for length or weight for height z-score, and moderate and severe get more significant. The other thing that I wanted to point out is inadequate nutrient intake meets criteria for malnutrition as well. So you can see a child that's only getting 75% of their estimated energy or protein needs meets criteria for mild malnutrition. And similarly, if you're between 25 and 50%, that's moderate. And if you're less than 25%, that is severe malnutrition. And that's going to come into play in a moment when we talk about nutritional intake as a component of cachexia measurement. So to kind of emphasize the importance of those z-scores, I did a study with some collaborators back in 2020, and we looked at kids in the first 3 years of life, so under 3 years of age, infants that were going through cancer therapy. And we looked at weight loss of 10% compared to z-scores and how many patients were affected by those criteria. As you may remember, 10% weight loss actually falls into the category of severe malnutrition. And the reason that I highlighted that in this study is because clinically, a 10% weight loss is what prompts us as clinicians to change the chemotherapy dose or to adjust the treatment strategy. So oftentimes when we are prompted as clinicians to adjust our dose, our treatment, we're already at the point of severe malnutrition, and that's highly problematic. So when we look at that 10% decrease, that clinical marker that many of us use, of these over 400 children that we treated, 25% of them experienced 10% decrease in weight. So a quarter of children under the age of 3 that were treated at our institution, and this was done when I was a fellow at Children's Healthcare of Atlanta, experienced severe malnutrition. When we look at the numbers related to decrease in weight for age z-score or weight for height z-score, those were closer to 50, almost 70%. And so those, which makes sense, more children I would expect experience mild malnutrition than severe. But when you think about that, almost 3/4 of our, or say 2/3 of our patients are experiencing at least mild malnutrition. When we look at the comparison between this, of the patients that experience 10% decrease in their weight, almost 100% of them experience that weight for age or weight for height z-score drop, which makes sense, right? 10% is severe malnutrition, and those markers are mild malnutrition. But when you look at the patients who experienced a 1-point drop in z-scores, only 36 and 42% of them experienced a 10% weight. So it's possible that up to 40% of patients that are experiencing mild malnutrition aren't actually having any adjustments in their cancer-directed therapy, which may actually result in more toxicity and more long-term morbidity. And so I hope these first slides have kind of emphasized some of the unique challenges in defining and studying childhood cancer cachexia. And to emphasize that point, when we look at the adult world, how we've defined cancer cachexia as a community, a lot of it is weight-based loss. I pulled out this figure from the paper published by Fearon et al. In 2011 with the Fearon criteria of how we think about pre-cachexia, cachexia, and refractory cachexia. And what you see here, a pre-cachectic state was kind of characterized by weight loss of less than 5%, but having some anorexia and metabolic changes. In the cachexia state, weight loss is greater than 5%, or a BMI less than 20, or with weight loss greater than 2%, or sarcopenia and weight loss greater than 2%. So what I'm going to talk about in some of the coming slides is that actually, right, like these criteria are not directly applicable to children, and why it's really important that we have pediatric specific definitions and criteria to follow. And then in the refractory cachexia state, there's a variable degree of cachexia that's experienced. Cancer as a disease is both pro-catabolic and oftentimes not responsive to anti-cancer treatment. And the patients that are experiencing refractory cachexia have a really low performance score and less than 3 months expected survival. So performance score is another area that does not directly translate to kids. And we use variable measures to assess performance in kids that are very young versus our adolescents that are closer to adult functioning. And then finally, when you experience refractory cachexia in the setting of refractory cancer disease, it ultimately results in death. So in 2020, Eric Rowland and the group at ASCO put out guidelines on the management of cancer. And I included this portion because I think the way they described cancer cachexia in their, or cachexia in their paper is really important and emphasizes some of the key areas that are important to focus on as we think about identifying and managing cachexia in children. So cachexia is a multifactorial syndrome characterized by loss of weight, loss of appetite, loss of skeletal muscle, and it results in those objective measures leading to subjective fatigue, functional impairment, increased treatment-related toxicity, poor quality of life, and reduced survival. And as I mentioned, the appetite, weight, and skeletal muscle are objective measures. And in the adult community, we do have objective tools to measure fatigue, functional impairment, quality of life, and ultimately survival. But in 2022, along with Teresa and Andrea, we put out a commentary on the urgent need to improve childhood cancer cachexia and really highlighted the differences between pediatric cancer cachexia and adult cancer cachexia. And in that paper, we described several of the unique challenges to classifying pediatric cancer cachexia, starting with the measures. I pulled out those terms that I highlighted in the ASCO management paper, including loss of appetite, loss of weight or muscle, fatigue, functional impairment, toxicity, quality of life, and survival. And you can see in children versus adults, these measures are challenging to assess and result in a wide variety of different assessments, papers, publications, and research in the pediatric space, or none at all. So measuring appetite or intake, I don't have to tell anyone who has tried to feed a child that measuring what goes in their mouth versus what goes on the floor is a really big challenge. And assessing their intake outside of having a patient who is on total parenteral nutrition or very objectively measurable enteral nutrition can be really challenging. That loss of weight and muscle, there's not a lot of normalized data on how much weight or muscle muscle mass a child should have. And then at that point, also assessing loss versus growth impairment is really important. Fatigue is a real challenge in children. Measuring the patient's report of fatigue versus a parent perception of fatigue in their child. And then similar with functional impairment, developmental stage is a highly important and a highly variable assessment that differs between a 2-year-old, a 12-year-old, and a 21-year-old. Those toxicities, including changes on body composition, can be variable depending on the type of treatment that's being received and the age and the diagnosis of the patient. And then quality of life can be really challenging because we want to distinguish between how cachexia affects the quality of life of the caregiver versus how it affects the quality of life of the child going through cancer treatment versus the adult that is actually going through, the adult survivor of childhood cancer. And then finally, defining long-term. We hope that our patients are going to live for 20, 30, 40, even 50 years or more beyond when we treat them. And that's a very different model than treating an adult with cachexia and with cancer. And we know that cancer diagnoses affect malnutrition differently. This was a paper that was published in 2013 looking at children 0 to 18. Along the x-axis at the bottom, you see the day 0, so when patient is starting cancer-directed therapy, and along the right-hand side, you see 365 days. So what is the probability of a patient having malnutrition in that first year of cancer therapy? Up at the top, they classified medulloblastoma, osteosarcoma, and acute myeloid leukemia as having the highest, almost 80% probability of developing malnutrition. And then at the bottom were some of our low intensity or unable to classify tumors that were closer to 33% experience probability of malnutrition. And in the middle, neuroblastoma, Ewing sarcoma, other types of lymphoma, leukemia, and solid tumors, which make a real big difference in how we identify these tumors, and treatments are very different. So we recognize that the approach we need to take may be very different as well. As I mentioned, the nutritional needs are different for different cancers. So certain diagnoses and certain treatments have higher rates of malnutrition, and that's clear in the adult literature as well. This was a paper that we looked at to try to see about nutritional needs and intervention. So we took from the FIS database, which is a hospital and billing system database available where a lot of pediatric hospitals participate in sharing that information. And we created a definition of functional malnutrition. So that's either a diagnosis of malnutrition, a tube placement procedure, enteral formula supplementation that was billed, or parenteral nutrition that was billed to the patient as well. And we distinguished that functional malnutrition from a diagnosis only of malnutrition. And the reason that we wanted to do this particular study was because, as you may recall, inadequate intake actually meets criteria for malnutrition. And in kids, in pediatric hospitals, we are very fast to put down an NG tube to feed patients supplements, probably more so than in the adult world. So what you see along the y-axis is the percentage of patients that met either of these criteria, and along the x-axis, different types of solid tumor based on the body location. And you can see here in the middle, the highest patients that experienced functional malnutrition, over 60%, were either adrenal, liver, or biliary. So tumors that had either surgery, radiation, or chemotherapy directed towards the abdominal compartment. And my particular area of interest, central nervous system tumors, over 50% of those tumors, patients with those tumors experienced functional malnutrition, as we called it. So as we're thinking about how to intervene on these patients, thinking about the type of patient and the needs that they have is really important. And along those lines, we know that nutrition is not the only component of cachexia. There are biochemical and inflammatory path mediators of cachexia, and also a significant number of pathways that are involved in hunger, satiety, and body catabolism. So I took this from a paper that was just published in 2025 because I thought it really nicely summarized a lot of the potential pathways for that could be targets in cachexia. They highlight here in the first panel CNS components. IL-1 beta, leukemia inhibiting factor, and GDF15. Those factors that activate kind of centrally and stimulate either the hypothalamic pituitary axis, melanocortin system, or either of those spaces that results in a loss of appetite. Inadequate intake, which is certainly a key component of this. A second component potentially for targeting is the tumor metabolism. So we know that there's an interaction between the tumor microenvironment and energy utilization, kind of similarly housed within the liver, that is stimulated when there is cancer or cancer-directed therapy. Finally, fat wasting. Next, fat wasting. So we know that these catecholamines and inflammatory cytokines affect the breakdown and body composition or distribution of fat within the body. And then finally, muscle wasting that can be affected by glucocorticoids, activin, and these inflammatory pathways as well that lead to mitochondrial dysfunction and muscle breakdown. All of these are areas for opportunity for exploration in pediatrics. And what I would emphasize is that they're actually important and different from the pathways that may be active or may be affected in adults with cancer. And so back to that publication that we talked about, the ASCO recommendations for managing cachexia. I thought what was really important to highlight here was to just pull out some of the recommendations and highlight how they are different from children than they are in adults. What you see along here in the first column is we've got nutrition and appetite support, those appetite stimulants, antiemetics, and parenteral or enteral supplementation. Ghrelin as a potential mediator, GDF15 as a potential mediator, the JAK-STAT pathway, and other anti-inflammatory agents. And the recommendations that came out of that paper favored dietary counseling, progesterone analogs, and corticosteroids as components that have positive recommendations based on the literature with regard to cancer cachexia. There wasn't sufficient evidence to make recommendation along a whole host of these medications. And then there were weak or moderate or strong recommendations against several components as well. And what I just want to highlight is that in children right now, all we have is this first box here. And we really actually lean away from giving corticosteroids because we know that in long-term studies of survivors of childhood cancer, corticosteroid use actually has a really profound impact on bone health and some of these other factors that are long-term implications that may or may not be relevant in adults. So we really are limited in our toolbox for children with cancer. And I put this up here to just highlight that our studies are limited and we have fewer therapies that exist for childhood cancer cachexia. And it's really important that we put some dedicated time and resources in. So I hope I'm emphasizing these points and making firm advocates and believers in childhood cancer cachexia for all the groups that are on this call. And I think when we go back to the why, this paper was really powerful to me. It was published in 2023 and was focused on what families say regarding nutrition as they are caring for a child that is going through cancer treatment. And I just want to highlight this here as importance to the why. There's a lot of basic science researchers here that sometimes may not see the connection to the clinical space that we as clinicians do. And I think it's just so important to highlight the importance of this work and these communications. Here you see one parent highlighted that their taste buds change and she'll like something one week and the next week it's a hard no. a caregiver who expressed it was completely draining and depressing to try to spend the whole day trying to feed through an NG and then the patient just vomiting it up and not gaining any weight. And thinking about when you're raising a child, how important healthy eating is, but trying to just keep your child alive when he's a cancer patient, and not wanting him to lose weight. So fruits and veggies, sure, out the window, but really just getting anything that they can. So we really can and we must do better, and we must think about explorations beyond just nutritional supplementation. And that's where we come into the potential mediators of cancer cachexia in children. There's a lot of inflammatory pathways that I highlighted, and several papers that have put out kind of different pathways, opportunities for focus, and some of these things that actually run together. One in particular that I've kind of thought about, and under the mentorship of Teresa Zimmers, who's been a really great colleague, collaborator, and mentor, is growth differentiation factor 15. It's something that is pretty unexplored in the pediatric space and has gained some traction in the adult world. So what is growth differentiation factor 15? It's a member of the TGF-beta cytokine family. It is expressed in RNA and DNA in tumor tissue, and actually, in some studies, has conferred radiation and chemotherapy resistance for cancer. It circulates in the blood and crosses the blood-brain barrier, resulting in nausea, vomiting, and anorexia. And it also seems to have a role in peripherally increasing energy expenditure in the muscle and muscle breakdown. It seems to correlate to systemic damage in multiple inflammatory conditions, and we actually just published a review paper looking at all the different pediatric conditions that have looked at GDF-15. And then more importantly, it's been proposed as a therapeutic target in adult cachexia, which I think is an important consideration in thinking about what we can bring to pediatrics. It correlates with other inflammatory markers as well. So it may not be the only driver of damage in pediatric cancer cachexia, but it does appear to be part of a broader inflammatory milieu. It has a positive relationship with IL-6, which is a known cachexia mediator, and CRP, which is a commonly identified damaging inflammatory mediator. And this was a study in 2021, actually in patients with COVID, because again, there aren't a lot of studies of GDF-15 in children with cancer, but looked at the correlation between IL-6, CRP, and GDF-15, and showed less of a correlation with ferritin, D-dimer, and neutrophil count, but inversely related to lymphocyte count, which we know is something that is a component of inflammation as well. I think the most compelling argument was really nicely characterized by this cartoon as part of a paper published by Borner in 2020. On the left-hand panel, you see that there were rats and shrews that, when given GDF-15, experienced pica, anorexia, weight loss, and in some cases, ultimately death. And subsequently, when cisplatin is administered in the second panel, you see that resulted in the increased secretion of hepatic GDF-15, resulted in increased circulating GDF-15, and that interaction between GDF-15 and GFRAL in the CNS, which led to emesis, nausea, anorexia, and weight loss. And that correlation between GDF-15 and reduction in feeding was pretty profound. So the higher the GDF-15 went up on the y-axis, the greater reduction in feeding that the animals experienced. And more important to that point is blunting the effects of GDF-15 improved body weight. So when GDF-15, again, on the y-axis here, change in body weight is on the y-axis, and days post GDF-15 is on the x-axis. When GDF-15 was given in the red line here, you saw that there was a pretty profound and persistent weight loss experienced by these animals. When GDF-15 was given with a neural toxin that disrupts that pathway, GDF-15 did not seem to change the body weight at all. And that was consistent with the placebo, the PBS solid black line here. When the placebo was given with that neural toxin, those mice actually experienced an increase in weight. So I think it's an important emphasis of the potential importance for exploring GDF-15 in this population. So a few years ago, we did a study looking at children with newly diagnosed cancer, and we did a comparison between them and age and sex matched controls. So patients that were getting an MRI for non-cancer reasons, we do a blood sample and checked GDF-15 levels in that population. And what we found is that children with cancer had a higher median GDF-15 level compared to healthy controls, almost double that. And what you can also see, looking at this blue box here, is that the cancer population had a significant rightward skew. You had some patients that were actually really high in the thousands of GDF15 levels, but almost all the cancer patients were actually above the median level for the control group, which experienced both a lower median level and a normal distribution compared to the cancer population. When we did a 3-month follow-up, those patients had sustained elevation. And one of the other things we were trying to capture, but weren't powered to detect, were changes in body composition, nutritional support, and quality of life. And as I alluded to earlier, there was kind of this hallmark paper that came out in the New England Journal of Medicine in 2024, looking at ponsegromab, a drug that is a GDF15 antagonist for the treatment of cancer cachexia in adults. And it showed really promising results in decreasing gastrointestinal-related side effects, maintaining weight, but also importantly, maintaining muscle mass as well. When it comes to what's missing, though, from the pediatric population, we need to figure out which patient population is important to study. As I told you earlier, that certain cancer diagnoses are associated with higher risks of malnutrition and require more intense nutritional support. And we want to know how different therapies affect GDF15 differently, so that we can identify if there's a drug like ponsegromab, is that something that makes sense to bring to pediatrics? So in this study in vitro, when cell lines were given exposed to different chemotherapy agents, which we know are highly emetogenic or highly nauseating, bleomycin and cisplatin upregulated the expression of GDF15 mRNA in those cells. And similarly, when studied in patients, circulating GDF15 actually rises over time with exposure to known emetogenic chemotherapy. And you can really see that here in a study that was published in 2015, looking at patients with testicular cancer who were receiving bleomycin or platinum-based chemotherapy. They experienced an acute rise in GDF15 from day 1 compared to day 8, and then a little bit of a decrease a week later at day 15, but still above that day 1 level. That day 8 rise in GDF15 appears to be more pronounced with subsequent cycle. So you can see highlighted with this red box, this is the day 8 level, cycle 3, so 3 months later, essentially. Circulating GDF15 seems to return to baseline over time, this suggests to me that there may be a role in GDF15 in that gastrointestinal toxicity, as well as some of that muscle catabolism and malnutrition experienced during cancer therapy. Now, this is just some of the numeric values, and what I wanted to highlight here is that the beginning, their day 1 course 1 in adults was actually pretty similar to our control group in my pilot study, but has a really wide range, as you can see here. And that 1 year after the start of chemotherapy, those numbers are roughly similar, but again, had a pretty wide range there. So based on all of this, my research is really focused and interested in exploring how GDF15 may or may not be central to the regulation of all these different mediators between the healthy child and the development of cancer cachexia. So, you'll see here that I've highlighted there is a role to play in how GDF15 may regulate anorexia and decrease appetite, even in the healthy child. It is related to cancer treatment and tissue-related damage, as well as chemotherapy-induced nausea and vomiting and muscle and fat loss. So based on that those adult studies, I think there are further opportunities to study GDF15 in pediatric cancer. And I'm just going to highlight a few things that I'm working on currently, and then take the last few minutes to talk about how we might think about designing clinical trial investigations for children. So first, what is the normal distribution of GDF15 in healthy children? We don't actually have that data, but I'm working with a group on ongoing efforts to better characterize GDF15 levels based on age and biologic sex in just the general population. If we're going to use this as a marker of cachexia or cancer-related inflammation, we have to know what GDF15 looks like in the child, which is a different population and different physiology than an adult. How does chemotherapy affect GDF15 over time? So there are some groups that are doing longitudinal studies here. And at my institution with some collaborators, we're working on individual chemotherapy evaluation. So pre and post chemotherapy, how is GDF15 changing over time? Is GDF15 tied to changes in appetite or body composition? So we're looking at now different ways to assess body composition, muscle mass and fat mass, and see if that correlates with changes in GDF15. And does GDF15 actually change the patient's objective or subjective assessment of their intake and appetite? What other mediators of cachexia are relevant in children? GDF15 is a place where I started, but I'm working with some collaborators, several of whom are on this call right now, to retrospectively examine some proteomic expression of common cancer cachexia mediators to explore common cachexia mediators that have been studied in adults in those pediatric samples that we have, basically to inform what we might want to look at prospectively with future trials. And then ultimately, how can we optimally design a childhood cancer cachexia clinical trial? I think ultimately that's what it comes to, is if we want to take these, we have to have a universal language to assess the patients, the population, how we describe childhood cancer cachexia, and how we study and measure outcomes and interventions. So in just how we might envision a clinical trial, we want to think about what is the right age in the population. As you've heard during this talk, ages have different metabolic processes, have different susceptibilities or possibilities of developing malnutrition. The diagnosis and stage of the cancer, do we focus on end stage diseases like they've done in adults, or do we work earlier to try to prevent cachexia and stave off some of these long-term morbidities and mortalities? What are our endpoints? Weight loss, or is it muscle loss? How do we assess body composition? Or do we look at survival? Do we look at kind of traditional cancer outcomes and how we study cancer-directed therapies in clinical trials? And to that point, do we expand beyond those traditional cancer treatment-focused endpoints? Are our endpoints really going to be quality of life, symptom or side effect? Or healthcare utilization? We know that kids who experience malnutrition have higher hospital lengths of stay, significantly more inpatient costs, and significant socioeconomic impacts to the families. So perhaps these are the measures that we want to measure as outpoints. And what is the right intervention? Do we think about a pharmacologic or a mechanism-focused approach, or do we start even more basic than that with nutrition or exercise-based interventions to, really emphasize optimal delivery of nutritional support? And ultimately, I think designing a trial is probably going to involve all of these things in some combination, and maybe different trials focused on different components with the right intervention for the right patient population. So to that end, really appreciate the support from the Cancer Cachexia Society. You may all, members of the society may have seen an email sending out about interest in developing a pediatric cachexia network. So we're working on establishing a group to focus and highlight on pediatric specific cancer cachexia research and clinical care. The first piece of that is really the educational seminar. So everyone who's here today, thank you for joining. In July, we're going to be gathering over 30 representatives from the lab, the clinic, from patient advocacy and industry to look at how we might think about defining childhood cancer cachexia, and then what patient-reported outcomes and clinical trial focuses may look like. We hope to publish the meeting report from the outcomes of that discussion and use that as a stepping stone to an emerging topic session. So another plug for joining the Cancer Cachexia Society meeting in Torino, Italy in September. There's going to be an emerging topic session on pediatrics as well. And we hope to use all of these components to develop work on a consensus guideline for publication, either at Delphi or white paper, to put these out and say, to better serve these patients and to do the science better, we need to all be speaking the same language, and we all need to be focused in the same space. So to that end, I have worked with a lot of people along my career, and I'm so thankful for the folks who have helped me with the GDF15 project I'm working on here at my current institution at Seattle Children's, my former collaborators and continued collaborators at Indiana University, and the folks who are external to my institution listed here, as well as my research team and my neuro-oncology clinical partners who help take care of the patients, to allow us to do some of this research as well. So when I open it up for questions and comments, I really am interested in feedback. I always want to certainly improve the way I deliver and communicate. But also, if you're interested in just collaborating on childhood cancer cachexia, you have other thoughts about content area that should be included, please feel free to scan this QR code. It takes you to a survey where you can give me an evaluation. So selfishly, I can use those teaching evaluations for promotion. But more importantly, we can start to build those relationships to make sure that we are building these resources all across the world. I do have a slide, the requisite slide that has all the resources. But if you're really interested, feel free to reach out to me, and I'm happy to share any additional information about this talk. So happy to open it up to any questions, and thank you so much again for the opportunity to come and speak today.
Thank you very much, Dan, for the amazing talk. It was really, really interesting. Thank you for sharing all those thoughts and resources with us. So just to kindly remind you that you can put question in the chat, and you can also raise your hands if you want to ask your question in live. So while people are putting their question in the chat, we already have a few questions. So the first question is from Brittany Counts. She asked, do most children stay at the hospital during chemotherapy or therapy? And if it's the case, is this linked to malnutrition?
That's a great question. And the short answer is it is widely variable. So we have some children that experience, like say in the brain tumor world, they may get outpatient chemotherapy almost exclusively, where they're coming to clinic week after week, but spend very little time, if at all, in the hospital. On the other end, we have some patients that experience significant highly intense chemotherapies, including hematopoietic stem cell transplants or highly intense chemotherapy regimens that do require continued inpatient hospitalization. Now, it's a little bit of a chicken and an egg conversation there, because I don't know that you can say more time in the hospital leads to more malnutrition, or the treatments that we give, which are more likely to result in malnutrition, result in longer hospital stays. But what is clear is that children who experience malnutrition during cancer treatment, no matter what treatment that is, have longer hospital length of stay, higher rates of hospitalization, higher rates of infection, and more healthcare utilization.
And coming to that point, you often refer during your talk to the rate of comorbidities, but is cachexia in children also related to the prognosis or the outcome and the survival, like we see in adult cachexia?
It really has, that research is what I'm hoping to do, define more of, because we've never really considered cachexia as a phenotype, kind of the complex phenotype in children in the same way that we have in adults over the last few decades. What is known is that kids that experience undernutrition have worse survival. That data is very confounded. And so I think that's why I say some people still argue the question of, is there a clear connection between malnutrition and survival? And I think I clearly believe that there is. It's just cloudy based on the way that we have done our data to this point. But I think to your point, one of the hopes that we have as part of this working group is, let's develop some clear consensus guidelines so that we can say, this is how we call cancer cachexia. And we can say that patients who meet these criteria do have higher rates of death, or 20% more likely to, succumb to their illness.
I think it's much needed. I move on to the next question. Thank you very much. So we have a question from Mahavir Singh. My apologies about that. And so that person is asking, do all kinds of cancer types leads to GDF15 increase?
Great question. We don't know the answer to that, but that is what I'm trying to do now. So that first study that we did looking at different cancer types, it included all comers. So we had solid tumors, we had leukemia, lymphoma, a whole different variety of the data I didn't show of patients that had high GDF15 levels. All of our patients with cancer fell into that category. And Amanda, who I think is on the call still, is helping do some really exciting work exploring some of that. But we don't know that all children with cancer, with all different types of cancer, experience GDF15 elevation. What I think is probably more likely is that all patients who receive particular types of chemotherapy will experience GDF15 elevation. So I'm trying to do more of that dedicated study of, say, we need to look at different patient populations and different drugs specifically. The reason I highlight that is cisplatin is one drug that's used in children, highly emetogenic chemotherapy, meaning a lot of nausea and vomiting that's related to it. But it is given to kids that have brain tumors. It's given to kids that have osteosarcoma, a whole host of different diseases. And I think actually the more important focus is probably the treatment identified rather than the tumor identified. But to that end, there are studies that have looked at different types of high-grade gliomas, different types of colon cancers in adults. And those studies show that higher GDF15 expression in the tumor itself confers radiation resistance and chemotherapy resistance. So the short answer is I think it is both, but we don't have all those answers yet in pediatrics.
Thank you very much. So the next question is from Dr. Teresa Simmels. So what language do you use when you speak with family about cachexia? Do you use the word itself? How frequently do you use olanzapine for nausea, vomiting? And have you prescribed in longer term for cachexia?
Yeah, so olanzapine is one that's really commonly used. It's one of our kind of heavily leaned on from the appetite component and the nausea and vomiting component. I oftentimes don't use the term cachexia with families. I think that is probably changing over time. I think in current state, for most families, cachexia is still a jargon word. And so I talk about gastrointestinal symptoms, weight loss, and muscle loss. To this end, we have not started prescribing olanzapine specifically for patients that experience muscle loss, but it is a tool that we lean on in kids that have significant weight loss with nausea and vomiting. The challenge is you cannot use olanzapine you cannot use it in all ages. And it also has interactions with a lot of other antiemetics from like cardiac conduction issues. And so there are, for kids that are on active therapy, there are a lot of interactions that we have to be cognizant of with olanzapine.
Thank you very much. We have a question from Sham Kakar. Did you look muscle strength or dysfunction to other organs such as heart in addition to loss of weight?
Yeah,
Yeah.
Oh, sorry. Yeah,
No,
we
no,
did look at that specifically. Part of the reason is that one is there are a couple papers that have looked at GDF15 as a predictor of cardiac dysfunction in survivors of childhood cancer. So perhaps is it a mediator of kids that have experienced cardiotoxic chemotherapy? Is it a predictor of those that will experience heart failure, which is a little bit separate from your question? I didn't go into it in great detail, but muscle strength is really hard in kids. So trying to get like an 8-year-old, for example, to participate in like grip strength or 6-minute walk tests are really unreliable. And so actually that's why we kind of shifted back to thinking about body composition assessments. Like, can we use DEXA or air displacement plasmography to measure muscle and fat mass? Because the challenge is until we identify the best patient population, the functional measures or the strength measures are going to be different if you're studying an adolescent population versus a child population versus, say, a toddler population. But you highlight perfectly one of the huge struggles in pediatric cachexia research right there.
And this brings me to another question that I have. So functional assessment cannot be done like we used to do it in adults, sorry. But then about appetite measurements, I mean, how can you ask? I asked my son of 6 years old. He's always hungry, but I have no reliable information as he's really hungry or not. So.
Well, and that's why there are some tools that utilize both patient report and parent report. So there's some validated tools. The one that I've used most significantly is called the PEDS-QL. And it has different age ranges. So like say for a toddler, it only asks parent, not the participant. And then there's a different age for like school-age child, early adolescent and teenager. And that actually, but those are very different, right? So even in a study where I did 30 patients, I had patients between 2 and 20. And you have, so a handful of patients that measure this assessment, but the assessment we're using for a 2-year-old is very different. And, it's not always objective, which is, I think, why we need to work on sort of a bigger network where to say, like, I have a group of 20 adolescents. If I can pair them with the 20 adolescents in, London and Germany and different centers, then we can actually put those things together to say we're going to make some meaningful conclusions.
Thank you. We have a question from Megan Jolie. So kids are typically so active. Is actigraphy being considered as an adjunct to other quality of life assessment?
It is, I have not done that, but there's been a lot of work. St. Jude in particular has done a lot of work about mobility and tracking physical activity and physical function in those kids. To the same point about muscle measurement and physical function and quality of life measures, it's very different to measure again in a 2-year-old versus a 12-year-old versus a 20-year-old. But I completely agree that it is a huge importance to say, how are these children functionally doing when they experience cachexia, and how is that impacting long term? And the best way to measure that right now, what we have outside of like saying putting a Fitbit or an Apple Watch or a tracker of some kind on kids, what we have right now is subjective assessments from parents, which is hard, right? Your kid doesn't feel good. They took a 3-hour nap today. That's normal, and it's a challenge, but completely agree. It's a hugely important component to what we're talking about here.
Thank you.
I
Thank
have
you.
actually a curiosity, if I can. So we know that in adult cachexia is often diagnosed at the time of the cancer diagnosis. This is also true for the pediatric population, or is the treatment have actually a crucial role in this population?
Yeah, not always. And in fact, in the adult world, we know there's clear types of cancer that present with cachexia. Pancreatic cancer is a good example of that. It's actually not common for that to happen in children. Now, is it not? So weight loss does accompany some cancer diagnoses, but oftentimes kids are diagnosed before the point of actually meeting what we would think about as like the wasting syndrome that is seen in adults. Now, is that because we're not looking, because we haven't recorded that, or is it because there's something physiologic difference? I think that's important. But we are in pediatrics, I think as general pediatricians, we focus so much on weight gain and weight growth that we often, when there are more subtle changes, we catch those things more early. And at our institution, for example, when you're diagnosed with cancer, you get an NG cutoff weight. Like when you meet this criteria for weight loss, NG tube goes in, you get enteral supplementation, no questions asked, like that's that. And that is not the way that we care for adults with cancer.
That's very interesting. Thank you again. I'm really looking forward to attend this emerging topic session and to hear back from the workshop you're organizing in July. So thank you very much for sharing all this with us. Thank you very much for all the attendees for being there. As I indicated in the chat, so the recording of Dr. Daniel Runco will be made available on the website of our society for 1 month. So you have plenty of time to look at it, and don't forget also to fill the feedback questionnaire suggested by Dr. Runco. So thank you very much, everyone, and have a lovely day. See you soon. Bye.
Thank you so much.
Thank you.